Hi everybody, welcome back to Life Education's podcast. We're here with David Johnson, who is a sports therapist and Doctor of Osteopathy. And you're working at the IFBM in Dubai.
Yeah, in Healthcare City.
In Healthcare City. So we asked you here because I know you do a lot of teaching with some of the strengths of that's been in Dubai recently. But just wanted to have a chat generally about kind of the world of osteopathy and then what you've seen in your time in Dubai. Because I know you've been here for quite a while, how you've seen kind of the fitness industry progress. And you've also tried to bring a lot of educators over in the past.
Correct.
You did some work with Charles Poliquin.
Yes.
The late great Charles Poliquin, so we could talk about that as well. But do you want to just briefly introduce yourself first of all?
Okay. David Johnson. I started as a strength coach before I came to this country. And then I became a sports physical therapist through injuries, and later went on to get the title of Doctor of Osteopathy. I've been here roughly 13 years. I've established different medical practices and different businesses here. I've been an educator around the world, different places. I've even done things like seminars at the Royal College of Surgeons and some sort of prestigious places. And I'm currently in clinical practice here in Dubai.
What kind of stuff have you been teaching?
So it depends who I was with, but a lot of it is strength coach based or fitness based, if you like. So anything from overcoming strength plateaus, which is the last one I did at the Global Strength Summit with Desert Barbell, to hypertrophy, to strength training, through to using different methods. I have a seminar that I teach called AcuMuscle, which is taking very basic modalities of physical therapy and applying them to strength training in order to assess muscle weakness and instantly fix that muscle weakness, as long as it's not an injury. And that you can see people do that quite well.
Instantly? I love that word. Yeah. Explain.
Well, muscles turn off for different reasons. Mm-hmm. So you trick the nervous system. The nervous system shuts it down. So whether it's a Golgi tendon organ or a muscle spindle or any of these things, as long as, again, there's no injury involved, you can normally turn this back on and see instant results. So if you've got a rotator cuff that's pretty weak, you can test it. You've got to know how to muscle test very well, and then interpret those tests and then apply the techniques. And I, when I was refining it, one of the funny stories is a good friend of mine has nothing to do with health and fitness or the body whatsoever. He's in London, and I sat in Starbucks trying to find a way that I could teach him to do it. And I put on the back of a napkin so I could get him within under 5 minutes to understand the concept. So you can basically teach anyone. And that was the key. And then obviously you've got to know your anatomy, and we teach the anatomy, and hopefully people come with that background.
So how did you teach him in under 5 minutes if we started a clock?
That would give everything away, see.
Okay, that's your whole course in 5 minutes.
Whole course in 5 minutes.
So I'm curious because in kinesiology there's a very similar practice.
Yep.
Where they muscle test.
Yep.
And then they turn things back on. I've been very fortunate enough to have one of those when my my tummy muscles were just not on.
Yep.
And then you turn them back on. I was like, how did you do that?
Yeah.
But I think it's through manipulation. Is your technique the same?
So manipulation can mean a multitude of things. It can mean, most people think it's the pop that chiros and osteos do. That's one form of manipulation. It's called a high velocity low amplitude thrust. That's not what we do on the courses, for example. But manipulation for us is just anything you can apply or use your hands with, basically. And yes, that's what we do. So you fight. But the key really is, in all medicine, the key is diagnosis. And so we talk about pet peeves and things like that. And here is one of my pet peeves is that people are treating with modalities and not giving it a diagnosis. So people walk into my office, I've had this, I've seen different physios, chiros, osteos, whatever, many, many times. I say, great. What was your diagnosis? 0. Okay, so what were they working with? So you're applying a dry needling session, or you're applying a fascial manipulation session, or what are you treating? And so when I've been here 13 years, this is what I see is a commonality. And people are selling this as packages. So you can go in and it's like, I call it the fluffy towel syndrome. You go in and you get a nice big fluffy towel, and you got that, it's like a spa day, and you go in and get, I haven't looked after. What are you treating? And I see that all the time here. And I see it worldwide, but it's very common here because of the fluffy towel syndrome. And so when you go back to it, again, a form of manipulation is part of a toolbox. So I like to say it doesn't matter what your profession, if you're a physio, an osteo, I've done all these different things. You should be able to go in a toolbox and pick out the tool that's needed for that diagnosis at that time.
So explain to me some of the reasons why a particular muscle might not be switched on, and then how is it different from when people have injuries? What changes?
I think when somebody has an injury, so what is the injury, first of all? So is it an injury to the joint? The joint.
Well, let's actually, sorry to interrupt you, let's start with when people are healthy.
Okay. So if you're healthy, it's normally probably just a dysfunction. So something's gone wrong. You've knocked it. You've strained it a little bit, so it's caused the system to turn off like an error on a computer. There's nothing really wrong with a computer. It just needs a reboot, and that's the way I look at it. So the nervous system commands everything. So whether you're strength training or you're doing anything to do with muscles or anything, the nervous system to me is king. And so that will dictate whether or not the muscles are working. So when you warm up, for example, in weight training, are you warming up the cellular activities or the neurological? You should really pay attention to the neurological activity first. And if you can do that, you get a better response.
How would you warm up the neurological system?
And so for me, it's people say go and a typical thing in PTs is you go do a 10-minute warm up on the bike, and then I'll see you. Okay, that's temperature. We can argue that and not. I like to be very, very specific, and I would say, right, if we're bench pressing today, for example, you're going to warm up on the bench press. You're not going to do more than 5 or 6 reps ever on the warm up, and then we're going to decrease the reps as we add the loads. So your body needs to know 2 things: the range of motion and the load you're going to lift in order to do for that session, for example. Now, if you're going to run a 10K, you don't warm up the bench press. You go warm up 10K. It's very, very specific to what you're doing. But the nervous system needs to know what's going to happen. So what I see is people go in the gym and they go, I'm going to do a set 10, a set 12. I'm going to spend 10 minutes on the treadmill first. I'm going to do a lot of sets at higher repetitions to warm up. They've got to warm up. Well, yes, you warm up to raise the core temperature of the muscle. I agree. There's more pliability, better responses. But you've also got to do it systematically. So if you're going to bench from nothing to 50 kilo dumbbells, you've got a lot of sets to warm up. How are you going to do that without fatigue? And I want the nervous system to be responsible for your activities and not just think about the cellular component, which is what we think about carbs, we think about the lactic acid. That's all cellular. Who's warming up the nervous system? Who's turning that on? That's what I'm more concerned in.
Okay, and then if somebody has an injury, why would the nervous system turn off a muscle?
It's sheerly to protect what's going on.
Okay, so it's purely protection.
Yeah. And some people can recover from injuries, and that injury is completely gone, but the nervous system hasn't accepted that. So you just got to teach it it's okay to do it now, and that's part of rehab.
Yeah, nervous system is an interesting little thing.
How did they turn your abs back on when you did it? What was the exercise or what was the thing you experienced?
To be honest with you, I can't remember entirely, but I remember laying down, obviously, on a bed, and they made me do in Pilates what you would call like a teaser. So you come up using your tummy, and then he just pressed down on my knees and down on my torso, and I just went and then I think it was a spinal manipulation, and I think it was T12, and he adjusted T12, am I right? And then I did the same exercise again. So it was a crack manipulation, to be technical. Yeah. and then I did the same exercise 2 or 3 times more, and I was a lot stronger. But yeah, but it's interesting. I think I've said this several times on this podcast, so I'm sorry if I'm going to repeat myself. But I remember having a surgery once on my foot, and the surgeon took a video of my foot in the in the post-op room after. I was obviously passed out. And he showed my toe having full range of motion. And when I got out of surgery, he's like, look, I fixed it. I can't give you this video, but I'm going to show you. I fixed your foot. There's full range of motion. And when I woke up and I tried to do that again, it didn't. It was stuck again to exactly where it was before. And I was like trying to talk to my toe, like, come on, we fixed you. Yeah. You should be, but no. And I have a feeling that that's entirely the nervous system. So my nervous system's like, we're not doing that.
You see that a lot. I've been in a lot of I've had the fortunate ability to be able to sit back in surgeries and watch surgeries. And I worked with one particular partner of mine at the time, and we a lot of ACL surgeries. So post ACL, what you do is once the surgery's done, they get the knee and they go into full flexion and extension to show that it's fully normal. We call that passive range, right?
Yeah.
Just full passive range of motion, and it's beautiful. Joint
but you
works.
Also have a completely sedated person
Yes.
that is passed out and drugged out to the nines.
But what does that tell you? Your system's turned off, right?
Yeah, entirely.
So from a mechanical point of view, that joint should work. Okay, when you wake up, the nervous system goes, hello, what did you just do to me? And so people come out and say, I can't put weight on it. Obviously, there's pain involved. There's feedback loops there. And then there's, you've done something to me. So surgery is a trauma. You're going to cut somebody, the body sees it as a trauma. What's gone on here, It's a very controlled, very thought, meticulous trauma, but it is a trauma.
Yeah, and it's probably a bigger trauma than the initial trauma, I think, sometimes.
Yeah, I think it depends on your trauma, but yeah.
Trust me. Sometimes it took me longer to recover from a surgery than well, who knows? Really, that's speculation, but...
Yeah, so, and through the rehab process, you have to teach them that you have full range of motion, and that we're going to have to ask your brain and your muscles to work together again.
So you trick it.
You trick it. And so you basically say, come on, it's time now.
How do you trick it? I want to trick my toe.
He's got to keep tricking. He's got to keep doing it. Like I tell people that when...
I'm still trying to trick it.
Yeah, well, are you gymming still?
Another conversation.
Do you want to move on, or should we talk about that? Okay.
No, let's not talk about that.
Because I talk to people all the time about, look, you've got a hurty knee, you've got a hurty toe, all the scans are okay. Why are we doing this? Well, we just need to find that sweet spot where your body's able to move before the pain kicks in, and we're just going to tell the brain that's okay, and eventually the brain's going to calm that down. Sometimes you get a really quick response just from movement away out of the pain. Once you kind of trip the pain switch, then it all flares up and gets very sensitive, and you have to back off quite a bit. But people are amazed when they have spent so long in clinics, like you were talking about, with the modalities, getting the thing on, getting the massage, getting the pads and the ultrasound. None of it works. They think they're completely bust up. Structurally, this injury was happened ages and ages ago. Like you should be able to get going now. Then tissue's healed. Let's just get you moving. And it doesn't take very long with some people. Some people it takes ages, but that's just tricking the nervous system. That's just trying to coach it into, listen, you can move. You just don't go over there with those dumbbells and start lunging with like 20 kilos the way you used it 5 years ago. But what other ways would you trick it? Like, do you have any strategies?
Post-surgery, I really like EMS, so muscle stim, using an electronic stimulator. So a lot of people post-surgery, so again, it would take ACOs, which is probably what I have the most experience with, probably 3,000-4,000 of those, is you see a lot of muscle wastage, and the brain's kind of forgotten how to use that muscle. And muscle wastage happens almost instantly. You went in with a quad, you came out with that one. It's phenomenal how the body just protects the joint. And then you just have to stimulate the muscle and say, it's okay, we need you to contract. And you've got to make that connection. But what I get people to do while they're having the stims, not just lay back and chill out and have a coffee, is you've got to actively think about contracting out when it contracts too. I need you to go back in with the brain and say, that's a normal response, that's a normal response, that's a normal response. And I normally end up only doing probably 3 sessions. I mean, this is a 10-15 minute thing. It's no longer than that. 3 times in 1 week, and then they can reactivate their quads. Now it's time to start building them, and that's, depending on the injury, we go around how that needs to be done.
Let me just take you up to the point. Why would a quad disappear so quick? What's in your mind the reason for that?
Yeah, safety.
So why would the tissue get smaller?
Well, the atrophy is probably from the nervous system telling the muscle it's no longer needed. I mean, the atrophy is not, it's rapid. Within a week you see it really, but you tend to see people come out of surgery, they're wrapped up, you see them, and then as the dressings come off within a week, there's quite a lot of atrophy. There's non-usage. So people forget that we are constantly weight bearing. So you're constantly walking on your legs, you're constantly moving around. And now suddenly you're on crutches or your bed rest, and then you've got an injury to the knee. So there's no stimulation to it whatsoever. And with the injury, the body says, look, you're not allowed to use this anymore. That's what it seems like is a big trauma. Let it heal. And it knows. The body's far cleverer than we are. It has this innate intelligence, in my opinion. And I always tell patients that, look, your body's really, really smart. And there's no drug we can give you that I know of. And we do things with stem cells and stuff like that. But there's no drug I know of that can do what your body can do by itself. As long as we just say it's okay at each stage. And we go slowly. And I honestly believe that it's just pure protection. And it just shuts down everything 100%.
And so you've seen 3,000 to 4,000 ACL surgeries. What other wild or wacky surgeries have you seen?
Oh man, when CrossFit became big here, started seeing things called posterior shoulder dislocations. You don't really see them.
Yeah, I was gonna say.
Yeah. So people would do kipping, and then they would dislocate the shoulder backwards. So you normally see it anteriorly.
Yeah.
So you start seeing weird things like that. Yeah, and you go, where did that come from? And then you got things like cellulitis or and things that need antibiotics. You see a few things. You got to be able to diagnose. So that means people walk into your clinic and they might have something that presents as a musculoskeletal symptom, and it's not, so it's disease. I think that's a really important thing. I've seen people come in with rheums that people think, oh, it's I've got this pain, it's muscular, can you just massage it? And then you end up something a bit more sinister. Yeah.
Go ahead.
I was going to ask you, do you think people are over-prescribing surgery? Like, do you think that people are having too much surgery?
So a lot of my partners have been orthopedic surgeons, and I've worked with good ones. I can say that I do see a lot of unnecessary things happening.
You can say, or you can't?
Yeah, I can. Yeah.
You can, yeah.
In my opinion, I'm not a surgeon, right? So from a non-surgical point of view, I think things like having your acromion shaved is no longer necessary unless it's the main cause of you've got a type 3, but impingement itself can be fixed in 5 minutes, literally. So I don't know what we're looking at, Now, is that the surgeon's fault? Probably not. They go in and they've said go to physio 500 times and do this, and it's the last resort. And it should always be a last resort.
Definitely. So this is a very simplistic idea, but I always wonder. So we are supposedly living a very sedentary lifestyle in comparison to the rest of human history, where we were much more laborious. Yet we're having more surgery from doing nothing than ever before. Obviously, we didn't have surgery, pre.
But is that an identification problem, right? So the minute you start monitoring, or the minute you have the technologies to have these, is it just the fact that we're finding these things and they can be fixed?
Yeah.
So is that the stat, right?
Yeah. Yeah, is that it, or is it this is like a new thing we've managed to give people a way to fix these things without feeling any pain, so let's do it, as opposed to being, if surgery was the way that it was before, when you used to get strapped to a table and like something put into your mouth and then they used to just cut you open with no anesthesia, no one would do that. No one. Literally. But now, because you like your little soft pillow thing now, because you can be put to sleep, you wake up, you feel no pain, like it's such a lovely experience. Let's all have surgery. Do you understand what I'm saying?
Yeah, I mean, I disagree in a sense that I think that's what technology has allowed us to do, right? So we've come so far, and
it's a double-edged sword, though.
Yeah, I think that's in the hands of the prescribing surgeons to know the patient in front of them. And I don't think anybody goes to med school not wanting to help people. I think doctors get a bad name and they get bashed a lot. And I really don't like it. I think we're all in the same medical profession to help each other and help patients. That's what we're there for.
Look, I totally agree with you in that perspective. I don't think anybody goes out to do any harm, but I also think that there's probably information about the human body that we haven't even tapped into, and how the human body communicates, and how on a really, really, really like you were talking about the innate intelligence on a cellular level, that we are messing up because we are just cutting everything open, not allowing it to heal itself, or not giving it the tools to be able to do that on its own, and being very quick to go to a solution that we know works, so to speak, without exploring other options. So that's
a double-edged sword there, isn't it?
Yeah.
That's totally, that's politically, ethically, and morally a very double-edged sword.
Explain.
These are the tools we have today available to us. So if you walk into me as a medical professional and say, I have impingement, and I go, well, let the body heal itself. We have these other ways of looking at it. We have these systems in place in our society to help protect the patient from malpractice. And so if you're not giving them what we now know currently are the best tools that we have available, that becomes then malpractice, right? And that means that you're now liable for...
Well, I didn't just say, oh, let the body heal itself and walk away, but giving it other tools that are less invasive. Like you were saying, you can fix an impingement in 5 minutes without having surgery, without having to shave.
So this kind, I think, comes back to, it's nothing to do with the surgeons. The surgeons are, I don't know anything about it. When I walk into an OR, an operating room, I don't know anything, right? And I think doctors also go into physio's office, and the good ones I've worked with, the surgeons go, I don't know, this is not my realm. This is what you do. And I've got very good friends who are very good consultant orthopedics in the United Kingdom, top of their game, and they say to me, surgery by itself doesn't fix the problem. You need a great rehab, you need great surgery, and they need to go together very well in order for you to have a great outcome. One without the other, there is no great outcome. We need you as much as you need us, right? And we need you to be as specific and educated as we are. Like we learn new surgical techniques, we learn new things that go on, we look at new research all the time. So the problem is, in my opinion, when you go into a physio's office, when's the last time they did a course that challenged them? When was the last time they looked at a different point of view? You know, that kind of education, once you get your first degree as a physio, you don't need to really, there's some CPD points, like 10 points a year, right? It's not a large amount. You don't need to have a master's to be competitive. Maybe you might want to, but then what do you do? You know, how do you keep up with things? What's happening? Some people are lucky that they have groups or circles that they work in where they do, you know, research reviews, or somebody has new techniques they can bring in and stuff like that. But I think when I came here, there's nothing. You know, certainly 13 years ago, there was absolutely nothing. And over the years, it's now much better than it's ever been. There's some great stuff coming in now. And like I said, I've tried to bring people in from the US before and stuff like that. And that proved futile because nobody wanted to pay the money. They're not interested, right? Maybe that model has changed now. I've kind of moved on from that, trying to bring people in. But I think it's still the responsibility of the therapist to be more educated. So if you don't know what's in front of you, or you have very limited experience, it's not okay just to plug the ultrasound on, which I see here in all the hospitals. It's amazing, you know. They just plug the ultrasound on, or they put me in wax, or they do some very basic things, a little bit of a mass, off you go, or a little bit of a band exercise, off you go. That's not acceptable, right? But it's also a business model. So medicine is also a business now, worldwide, not just here. And you see that a lot, which is, you know, it's very difficult to, I'll use the word play in that model, to give the best healthcare that you can give while you have these restrictions of.
Well, how like from your perspective, being in the industry for so long, how could you do that? How could you have a business and be giving your patients the best possible results? How would you do that if you see a lot of the opposite happening here?
I call it the cheat sheet, right? So you do your exams, you have a cheat sheet. For me, it's, you know, I don't use insurances. They're going to hate me for it, but I don't use them. They dictate how much you get paid. They dictate, you know, how many modalities you can put in a certain period of time. So it might be 15 minutes, you get paid for X amount for this modality. It's a very Americanized system, as far as I'm aware, and I don't like it. It dictates what you have to do for a patient. Well, how do you know what I have to do for a patient? Impingement, you got to do this. And it says you put this code in, and then you got 15 minutes. What do you do? Ultrasound, 15 minutes, then you did massage, 15 minutes, and you did patient education. And then you get paid for that time, and X amount of money, no matter your experiences. So I'm like, well, I'm sorry. We'll do pay and claim, which means that we are on the register. We have a stamp. You come into our place. You can, if your insurance is good, you can claim it back, all that kind of thing, which is 95% successful as far as I'm aware. But I don't. And a lot of places I've built before, we've had insurances because of, if you're a surgeon, you need insurances, and then the insurances have the rehabilitation with it, and a lot of people can't afford 20 sessions of rehab, for example, plus. And so you need them, but that dictates also how much you get paid, and it dictates how long you can spend with a patient a lot of the time, and then you have to fill those forms. And so I'm very, I'm anti it in the sense that we shouldn't be, insurance companies shouldn't be dictating what the medical provider needs to do in a particular consult. That's why we go to school, and that's why I spent my entire life, in education to get better at what I do. For somebody else to come along who's not as qualified as me and tell me what I need to do doesn't make any sense. And I think the patient in front of me is the most important thing. I can't emphasize that enough. When a patient sits in front of me, I'm here for you, right? You tell me what's wrong and how I can help you. That's my first thing. How can I help? I'm there to help. I'm not there to make money. I'm not there. That's not on my forefront of my mind. Where when you start putting every 15 minutes you have to do this, you're just going to wire people up and okay, we can see you tomorrow, we see you in 3 days time. This is what you do.
Yeah, or acupuncture one person and walk to somebody else and put them on an ultrasound so you can see multiple patients at the same time.
But this is what it's become because you got to get paid, right? And if you set up private practice in other places, not necessarily this country, but you can probably do that very well, make a lot of money and be respected and all that kind of stuff. It's not the way I like to work. I kind of see people about half an hour, and if they need more time, I'll express that and we do more time. Rehab can take, if you're really into rehabilitation, I don't have the facility, but we used to have a large facility where we did it. I'd be with patients anything from, half an hour to 45 to an hour sometimes, depending on the person and what they needed at that time. And we would book that in accordingly. And you can't necessarily do that in these models that are produced. So you've got to remember that everybody has to make money, right? So the facility that you're in needs to pay its rent, whether the lights are on or not. You need to realize that it's a business. And you need to realize that, if that doesn't exist, that service doesn't exist. So if we don't get paid, that service doesn't exist. I can't practice.
Well, like you were saying before, I liked how you mentioned about the like medical professionals, particularly surgeons, have to have a good relationship with osteos and physios so that the care can be comprehensive.
Yes.
In that regard, people understanding that, everyone lives through money. Like, we have to. It's not a bad thing at all. So finding a way to do it ethically so that both spectrums can be taken care of to a certain degree.
Absolutely.
I think it's a good way to look at it, because a lot of people do slam the surgeons pretty quick. A lot of people do say the surgeon's rubbish, the surgeon's this. And there is some bad surgeons. I had one guy who had his angles done wrong for his... I mean, I don't know. I can't critique this. One guy said a bunch of other doctors told him that his angles were done wrong for his ACL replacement. That's why it was still going wrong. That's way above my pay grade. I don't know. We just got on with it. But there's people who... I think bedside manner is a quick way to lose a patient's trust and... whatever else you want to call it. Like,
you've seen that stat in the US. They had this thing out, and I don't know where it's from, but I've seen it multiple times. Is you get a doctor who is precise, got a correct diagnosis, everything, but his bedside manner is not very good. Then you get the family doctor who hasn't got the right diagnosis, has been mistreating, etc., but a fantastic bedside manner, knows all the family. Who's likely to get sued? It is always the guy or the girl with the poorer bedside manner. And this is a stat from the US. It's very, very true. So that bedside manner is it's amazingly important to make that rapport with a patient.
I think that's where some surgeons might fall down. Again, I don't know all surgeons.
There's that thing that surgeons tend to, they're very good in the OR, not very good in the clinical room. So it's also part of the job, I think.
Look, from being down this avenue entirely, I think that a huge portion of this lays with the individual who is being operated on, not the surgeon itself. I think it's you, and it's your responsibility to make your own mind. How do I say this properly? You can either choose to heal or you can choose not to heal. And if you get the right surgeon or whoever it is and you follow everything that they say, because loads of people go to physios and the physios give them exercises and no one ever does them. We all know that. And follow all of those processes in addition to your own mind and your own how you perceive your own healing, then I think that the outcomes can be favorable. Unfortunately, I don't think people do all of those things, and I think the problem rests with the individual entirely and not so much with the surgeon. Like, it's up to you. Like, yes, there are extreme circumstances where surgeons are shit and they botch jobs up and they don't do a good job, or where you have someone who has bad bedside manner, but is that really it? Like, I think it's you. Like, I'm responsible.
It definitely is, but there's that idea that you kind of touched on. People just show up and expect, okay, I've got options. I take this back surgery, which is going to fix my disc. It's going to chop off the bit that's pressing on the spine. My pain will all be gone in a couple of weeks, and I'll be able to walk. Or we go through a year of rehab, and I fix my mobility and my core, and my and I go through this. Whoa, that's a really long list of things I have to do.
Because it's a lot of work. Yeah, that's the problem.
Exactly. And
it's a lot of work.
But they want to go skiing with their kids after in the springtime, or they want to do something. So why don't I just get the surgery now? And that's where people get misdirected, because they're
so I can get a surgeon and then do nothing. And when things go wrong, I can blame the surgeon because they're shit. It's not me. It's like, I could never possibly do anything wrong. Do you understand? I'm being sarcastic.
No,
I'm
on the same track as you. Like, this is, but I think it's not just as easy as people are lazy. I think people might be lazy, but their expectations are shifted. Oh, look, the surgeon's saying, listen, this is what I do. I know all about it. If you want that disc fixed, I can do it for you. Bish, bash, bosh. And then, like you said, precise, bum, 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 bum. Okay, next.
Maybe, sorry. This is meant to be about you, and I'm just rattling on. Maybe though it's how we as a society perceive surgery itself. Maybe it needs to be viewed differently. Like, I'm going to assist you with your injury, but you got to do half the work here. So I'm going to help this portion, somebody else is going to help this portion, and then that 50%, that's you. Like, that's on you.
So you ever see, my mum had a massive back surgery recently in the UK, and very successful, touch wood, all that. But my mother's generation, doctors were king. They were, no matter what they said, it was.
That's
you know,
true.
It was this thing, and then even as a generation, my generation, let alone sort of the generation after me, we're all now allowed to question everything, right? And so in our generation, I'm 40, so our generation is
You're
like
40.
Yeah, thanks for that.
You
I
look
didn't know
way
that.
older. I'm joking.
That's me leaving the door. See, this is what happens in memory loss. So then, the right to question things, and then you go back and you go. Now I question everyone. So my mother's surgery was a classic. The surgeon had never been asked a question in all his practice. Had never come out and met a patient's family pre-surgery, and obviously before when they did the appointment and everything. So I went in and I said, this is me. I need to meet the surgeon. And the way I approached the nurses, the way I approached the desk, it was in a London hospital, so not a great hospital in terms of the rapport that the people give you. And then we waited around, and the surgeon came out, and I went and sat in with the surgeon, and I spoke to them, obviously on a medical level, and my sister was there with me, and very, 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 very good. I came out, and the receptionist said to me, that's the first time in 2 years that he's ever come out. So in my head, I was like, A, is that because of him, or is it B, because nobody requests it?
What did she mean? That's the first time he's ever come out?
He's ever come out to speak to a patient's relative, especially on the day of surgeries,
okay.
right?
Yeah.
Which to me, in this country, is normal. You see the surgeons come out and say, good morning, all that kind of stuff. Now, a month before that, my best friend had, his mother had a massive surgery. And in the morning, everybody came and saw it. We saw the surgeon, we saw the anaesthetist, we saw the surgeon's assistant, and we saw everyone. But in this hospital, it wasn't done. But is it because nobody asked? Or is it because of the nature of the surgery? There was no orthopedics. I don't know. But I know that, again, ownership, you do have the right to ask as many questions as you want. And I think I find a lot of doctors don't like being questioned.
Yeah. I also found that a lot here. So I sit on, I think, yeah, I agree with you. I agree with you entirely. I know there was a time here where one of the surgeons to my pelvis wanted to fuse my pubic symphysis on the right and the left side and plate it. And I looked at him and I was like, no. And he was so shocked. Like, it's like I just beaten him with a stick. So shocked. He couldn't believe that I said no. And then he was like, no. He said no to me. And I was like, what? No, like, you're not saying no to me. I just said, no, we're not doing this. Anyway, he came back several times to try and convince me because I was wrong, apparently. And I probably was entirely wrong, and I can tell you now he was probably right. But my instinct at the time was no, and I was shocked.
Well,
no one said no.
Surgery needs informed consent, right? Informed means that you are completely informed about the surgery's risks, procedures, and what can and cannot go wrong with it. And that's from walking into the hospital to going down to the OR to risk of infection, just sitting in an OR, to coming out on the post complications that you can have post surgery. And if you're not informed of those things, that's malpractice. You need to be. And then in order for you to have that information, then you can make a decision. Do I think it's worth the risk-benefit ratio? And people don't do that. They go, I'm in pain. I'm just going to go in. Yes, doc, great. Thanks very much. No understanding of what's going on. So a lot of people come into my practice and I go, what did you have done? Oh, I don't know.
Yeah.
Just it said me shave something. I'm like, okay, that's an informed decision, right? What did he shave? My shoulder. What part of the shoulder did he shave? Like, I'm not expecting you to give me an anatomical landmark and talk about it, but I would like you to say, oh, the chromium thingy, that's fine. You've got a location. You can point to it. You know what's going on. You know what was meant to happen. 95%, 99% of my patients come in have no clue.
95, yeah.
I'm being, diplomatic, I guess, but no, most people come in having absolutely no clue.
Yeah.
He went in with my knee and he cleaned this. And I'm like, he cleaned what? Cleaned? What, did he use a bit of
I'm
Dettol? Like, what did he do?
Total opposite of that.
What does that mean? Like, and I have to ask always for the surgical notes. I go, well, what did he do? I don't know. Well, you need to go back and ask if it's okay. You get consent that I can see the surgical notes because I need to know what happened or what you did, right? And this is a commonality thing. It's very common in here.
Is that a difficult process?
It takes a little bit, but all patients should be able to, by law, get their surgical notes.
Yeah.
It may be a bit of getting on the phone and a bit of hounding, but they can get them for sure. Yeah. And they should email them to you. And
Amazing.
Yeah. You can get yours.
I know. You just gave me an idea.
No, you should have in all of your medical records.
Well, like, I'm a little bit nosy in that regard. I looked up all of the surgeries, read all the clinical studies, well, a huge majority to each of them, and then I watched them on YouTube.
So it is an interesting fact. The amount of patients that I've seen can stay awake in surgeries, right? So even if you have your ACL down, they can put a nerve block and you can stay awake. And the amount of people that basically sleep in surgery. And what I've seen, just from my own clinical experience, this is not a research, my own clinical experience, those that are awake have poor rehabilitation.
Really?
Yeah.
Poor?
It's poor. It's almost the shock and trauma of going through a surgery.
Let me tell you, when I watched my foot surgery on YouTube, my foot started hurting immediately.
Did you watch your own or a similar?
No. I watched the same procedure. It was like a YouTube description of what they do. I watched the whole thing, and my foot was killing me. I couldn't walk. It's bad. You should never watch. Never ever watch.
I think, if you haven't done cadaver dissections, if you haven't been to a medical school, for example, I mean, first year med school students, the first dissection you go into is people pass out, right? And there's no blood, really. So, let alone if you see operations, right? And like I said, I've seen quite a few. That's quite traumatic for a lot of people. Seeing blood for some people is enough to make them feel queasy and want to pass out, right? Or having massage, very painful. I don't like that. So you can imagine the level of going through watching your own surgery as it's happening and feeling those things. Obviously there's a nerve block, but you can still feel somebody's hammering into bone, for example, or screwing into bone. You can feel that, right?
Yeah.
So that's a trauma.
I've never had a surgery, so I don't know.
Do you know, once on the operating table, I went into, so normally they put you in the anesthesia room, you pass out, then they do the surgery. And one day they took me straight into the surgical room, and you see those huge orb lights. And I was looking at them, I was like, we're out in space. They moved me to another bed. They start doing everything around me. And I was like, guys, I'm still awake. I'm awake. Someone passed me out. I turned around and I saw all of the instruments, and I freaked out. It was like a saw. There was a saw in front of me. My heart just shot through the roof. And to the point when one of the guys, I started beeping on the monitors. The guy came, he held my hand. He's like, okay, we'll put you to sleep now. I was like, why are you letting me see all of this? It was not good.
Different patients respond very differently to different scenarios. So
I don't know how the surgeons do it either. Not to cut you off, sorry, but one of my friends is applying for a job to be when the operation happens, he's there doing the utensils, selling the kit, selling the equipment. I don't really understand it, but he's doing cranial surgeries. So part of the interview process is he has to go into a surgery and watch as a bystander to make sure that he doesn't pass out, he doesn't go queasy, he doesn't faint. Because if he does, then he doesn't get the job. And that's something that you can't fake.
No, not really.
But you
get
used to it for sure. Just like you were talking about the cadaver scenario, the first time I went into a scenario like that at university, it was like all the girls, we were all squealing, and the smell, and then you see this body, and you see, it's interesting because at first they give you arbitrary body parts that have been removed from the whole body. But then when you start going to anatomy of the head and neck, you start to see faces and facial features.
Little eyebrows.
And you see
eyelashes,
hair. And you get used to it. You get used to the smell. You get used to everything. You come out. Yeah, you get used to it.
Right? Yeah. So the more you're exposed to these things, the more you harden to those experiences.
Which is okay for you with 14 surgeries, but for me, who's going in for a knee thing, and I don't want to do that. Put me asleep. Put me out. Tell me what to do when I wake up.
Yeah. I always wonder though, how strong these drugs are. It's ether. Is it still ether?
I have no clue.
Yeah,
to be honest with you.
that they give to you. That's something. It's got to be so potent for you to be paralyzed and then not feel any pain. In addition,
it's a cocktail, right?
A
large cocktail.
Yeah, it's three main components. There's a hypnotic, a really, really strong pain medication, and then something that paralyzes your whole body, and it's together. One of the anesthesiologists was kind enough to explain this to me as he was about to knock me out.
Yeah.
But how potent that must be.
Yeah, I don't know. Surgery for some people is, I think, the right option to get it done, but it's hard to know when people have to make those decisions. Do you take surgery or do you go down the rehab route? Just going back to the original point, I think people they want the quick fix because they have a whole other life to continue. They haven't got time to just sit around and spend the time getting 50, 60. I mean, it's strange how people are happy to do the ACL one, and that's the longest rehab.
It's a long. People don't realize. People say, 3 months you'd be running around. I'm sorry, I've never seen it. Rubbish.
Yeah,
absolute rubbish.
Can you guys explain why it's so long? Why is that rehab particularly long?
You've got the tendon has to change to a ligament, first of all, the collagen, but also the position of it is it's so deep in the joint, it's not got a great blood supply. That's my rudimentary.
Yeah, so they drill a big hole in your bones, right, to attach the so that normally a lot of the time they take a tendon graft, and it can be from the patella or the hamstrings, and then they put that in place of where the ACL used to be. So you take away the old ACL.
Did they used to take it from the Achilles?
Not to my knowledge, no.
Okay.
It's normally a hamstring cruciatus graft or a
Okay.
patella tendon graft, or you get it from a cadaver.
Mm-hmm. Yes, the cadaver Achilles, though. No, I'm just gonna stop talking. Yeah.
And then they drill a hole, which is where you talk about the angles before. It's got to be the right angles and all that kind of stuff. And then they attach the new tendon to become.
And they drill it into the knee.
Yeah, so into the thigh bone and the lower leg bone, the tibia and the femur, at a certain angle, and then they attach those. And then when you have an ACL, I've never seen just an ACL. You normally get a bit of meniscus, there's cartilage damage, maybe there's a bone bruise, we call it. There's other things they need to do inside the knee. And they repair those or clean those up, and then they wash it out, test it, and then they stitch you up. And normally it's keyhole, we call it keyhole or arthroscopic surgery. And like my knee, you're left with 2 little marks.
You've had it done, have you?
I had a complex detached meniscal repair. My ACL was 50% intact, so I left it alone.
Okay.
But that took a full year to fully recover from. Yeah.
Say what it was again, a complex what?
Detached meniscus repair. So basically part of the meniscus breaks off and it's like floating around and gets stuck between the bones. So my knee got stuck at 90 degrees in a jiu-jitsu.
Is that how you did it?
I mean, I've been training for years, so I think I had lots of tears in them, to be honest. And that was the icing on the cake one day. And it got stuck at 90 degrees. And then I went to hospital, and there's a technique we use in orthopedics to kind of force it straight. So they gave me a massive painkiller, and then we forced it straight, and that was an experience. And then I had an MRI, which you have to do, and then you could see what was happening. And 3 days after that, I was in surgery. Because you can't bend your knee, basically.
Yeah, and that was a year.
And so the surgery obviously was very quick. It was about 45 minutes, 40 minutes. But recovery, because of what they did, they put the meniscus bit back and kind of stitched it in. And those stitches need to take place. You can't load weight, you can't put weight on your leg. And you can't bend it too much either. So there are only so many degrees you can bend it every week. So it took me quite a while to get full flexion. Even though I would work at it every day. Every day I'd put the electrostim on it. I'd sit there at night time. And there's on one of my Instagrams, is a very old one, just giving it a good blast of electrotherapy. And I would bend it as much as I could, even if it was a few degrees. Keep it moving, keep your toes wiggling, have it iced and all that kind of stuff. I was very meticulous about it.
Mm-hmm.
Good surgeon. And I was walking about 4 months, 3 months, 4 months. I was good, but I couldn't fully bend it, fully flex, and I couldn't do jumping and stuff for about a year. It took me to feel good. Now with ACLs, I see the same thing. So people can do things at 3 months and walking around and all that stuff, normally daily living activities. But the minute you want to start doing jumping, twisting, and pivoting sports, it takes a lot longer. And there's a lot of research that suggests the graft doesn't really it takes up to a year for it to mature.
Yeah.
And then we see, basically, those grafts can break if there's too much pressure on them too early. But I see people doing kind of crazy physio rehab plyometrics at 4 or 5 months, and I'm not convinced that that's a good thing to do for the general pop. Right?
Mm-hmm.
Now, for an elite footballer, something like cool.
Yeah.
And I'm sure they're a different breed in terms of what they're able to do anyway, and that's why they are elite. But when you apply that elite model to a general population, I think you're in for trouble.
Yeah.
And through my experience, I see massive weaknesses for a long period of time after.
Yeah, that was my experience as well. After I left hospital, I was given a 3-month, you could not work for 3 months. And it really took me a good 2 years to be able to do normal daily activities. And then the other stuff I'm still working on. I think recovery takes a lot longer than people think.
Yeah.
A lot longer. And I think because we don't realize how long it takes, we can jump to many other conclusions. People say, you're going to be fine in 3 months, but it really does take a lot longer.
It does. And again, nature of the surgery, the depth of the surgery, some things are pretty quick to bounce back from, a lot of things aren't. And ACLs, for example, are not, people go, it's a minor, don't worry about it, it's a minor surgery. It's not, it's a big surgery on the body. In terms of orthopedics, right? So when you replace an ACL, there's a lot that goes on, and people need to realize that it takes a while to come back from that.
There was a guy, when I worked at the military, there was a guy who, firstly there was a guy who had a below knee amputation, lying prone position, moved his leg, tipped a landmine, blew his foot and his shin off. Okay, he went down one medical route. His cousin was near an explosion, got embedded with a lot of shrapnel. One piece of shrapnel they took out. So in Camp Bastion in Afghanistan, they removed most of the bits that they could. And they said, look, there's a very large piece about the size of your thumbnail still in your hip bone. We're not going to touch that because to get that will cause you much more problems. So in Camp Bastion, before he was evacuated back to England, he could move around, very, very limited, but he could walk around by himself, kind of hopping around the ward. Landed in, I think it's Queen Elizabeth Hospital in Birmingham, which is the military one. They said, we'll be able to get that out. Put him through the surgery, couldn't get it out, caused so much trauma with the actual surgical process that the guy who had the below knee amputation was back on camp, running around on crutches with the prosthetic, playing football with the rest of the unit before that guy could even get off. He couldn't even walk properly because he had almost zero hip extension. So his walk was super limited. He was absolutely furious, and his rehab was just almost non-existent because he couldn't do anything. He went through a huge process, and that's just down to the damage that the surgery caused.
I don't know anything about the case, but I mean, again, it's informed consent, right? So I don't know what it's like in the military for that, but
he's also a very young guy. He was 18 or 19, because that's the only thing actually I wanted to talk about to you when you're saying when the patients come out from the surgeons and they say, oh yeah, I've got this or I've got that, and you don't really know. I really try and ram this home with people. If you don't understand what he's saying, write it down. Because you're not necessarily always needed to understand it, but you need to take that information to somebody else who does understand it.
I think the surgeon needs to back off a bit and use a bit of layman's terminology. So if you come into me, I'm not going to say you have a complex detached meniscal repair. You've got 50% ACL tear, the MCL is partially torn. We're going to do this, and this procedure. I mean, huh?
Yeah.
Right? I mean, imagine going into your accountant and getting to say, look at me and go, where's my money?
Yeah.
Like, what? It doesn't make any sense. So you have to say, listen, and let's draw a picture. This is what it looks like. That's why I have these pictures on my wall. This is what it looks like. This is what's torn.
Yeah.
This is floating around. All we're going to do is put it back, put some stitches in it. But that means that you can't put weight on it because look. Oh yeah. Right, it clicks. And let's go through that step-by-step process so that you understand it. Right? Yeah. And I do that with people who've had surgeries. I go, this is what's happened. This is what they've done. And then this is the process. And this is normally how long it takes on average. Now, it could be less, it could be longer, I don't know. Are you okay with this? Do you want to do this? Or are we going this way? But that layman's terms is a part of your bedside manner. Mm-hmm. And for me, it's extremely important. Again, my mum went into hospital, no real clue of what she's doing. Yeah. So I spoke to surgeons, and now I got the terminology. I said, what are you doing? And he explained it exactly to me like I was his senior registrar, and was just like, this is what we're going to do. This is what I said, great, thank you. My sister's like, huh? Yeah. I went out, and I said, this is what we're going to do. Very simple, but she should be fine.
I also think that when they do go into layman's terms, the people get it in the room, but as soon as you walk outside the door, if you're to try and recall it, they can't remember.
Yeah, so again, I sometimes I take a paper and say, please, you want to write this down? Yeah. Or I think if you I have a whiteboard a lot of time in the rooms that I practice, and so I use that as a form of, I think people are very visual a lot of time. And then they can picture it and they go, you may not know, this is called the meniscus. Look, this is where it is, and I show them in the knee. It's that little bit of cartilage in between the bones, acts like a washer. Mm-hmm. Oh, right, yeah. And this is what we do, and this is what it looks like. All right, 2 moon crescent. And then they won't forget that. Right? It's like a moon, right? Yeah, what is it? Like a moon. You get into repeat. Honestly, you go through that.
No, I agree. I totally understand, because I think some people as well just smile and nod because they want to kind of placate you. And I do get you. I get you. Maybe they do at the time when they walk out. It's like, what? I have people coming to me saying, the doctor said I have a disc.
I hope so.
I'm like, I know. I need a bit more. Like, just it's not your fault, but we have to figure something else out here.
Yeah, I get that all the time.
That's really your pet peeve, isn't it? I hear you say that so much.
it's I don't know. I mean, I do.
But if people don't know anatomy, they're not going to know.
Exactly. I'm totally agree with that. And I'm on their side, but it's like, you put all this hope into me trying to help you, and I don't even know what we're starting with. Like,
what's the diagnosis, right?
Yeah, I don't know where we are here. We need to just shoot in the dark a little bit now for a few minutes and see what works or what doesn't work, and then build a picture. And then I need to get in touch with your physio or whoever it was, because we're just going to waste a lot of time and a lot of money.
For sure.
Dave, where can people get a hold of you or follow your stuff online? Is there anywhere where they can look you up?
Clinically, I'm at the IFBM Building 72 in Healthcare City. I'm on Instagram, but it's more of a private one. That's
Sure.
DMJDXB. And there's all kinds of stuff on there. At the moment, I'm doing this coding challenge. Which
Yeah, I've been watching that. Yeah, I've been keeping an eye on that. The 100 Days of Code. I'm very interested to check that. We'll talk about this after.
Yeah.
Is there a website where people could check out?
No, not at the moment. I'm just a clinical practitioner mainly. Basically, yeah. So if you want to, you can go on the Instagram, and my number's on there also. Again, it's ifbm.ae, I think. And I'm available at the clinic.
Cool.
Amazing.
Yeah,
Thank you
thanks for
so
coming to
much
speak
for
to
your
us.
time.
Thank you for having me.
Hopefully have you on again sometime to talk about some of that education stuff that you're doing. Absolutely. See you again soon, guys. Thanks a lot.
Bye.